Now we'll go to the second part of our session. It will be a didactic talk on novel oral anticoagulants by the Dean of Cardiology, Dr. JABIR. And the session will be chaired by Dr. SHYAMALA MENON, who is the Senior Consultant Medicine at Medical Trust Hospital. Sorry. Madam SHYAMALA, please come and introduce Dr. JABIR.
Good evening, everybody. You know that today's talk is about the NOAC or the DOAC, that is the novel anticoagulant drugs. They have been among us for the last few years. I think they were introduced as an alternative to the conventional anticoagulants, and because of their safety and convenience, they stayed with the cardiologist for a long time. I think the physicians became interested in it after the onset of the pandemic, when they were being increasingly used. But of course, the use was mired in controversies. Anyway, to take us through this journey, we have Dr. JABIR A, a very experienced cardiologist, having an experience of more than 20 years in the field. He's a senior consultant and director of clinical research at Lisie Hospital, and he is well known for his organizational abilities. We know that he has organized many national and international conferences, and he is also a member of many societies, and he holds many important positions, like he is a member of the national CSI, the CSI, executive member of the national CSI. He is a national secretary for the Society for Heart Failure and Transplantation. He is the secretary for Cardiovascular Research Society and member secretary of Ethics Committee, CSI Kerala Chapter. Dr. JABIR,
thank you.
The podium is yours.
Thank you, madam. Good evening, and it's a pleasure to be here for a meeting in person. It's a long time since we had such meetings, and in fact, meetings were the best places where we connect, we exchange our ideas, and we shared good moments. And that pleasure was taken away from us for last 2 years because of this funny virus. I think we are gradually back to our own good days, and in future I think we'll be seeing more and more of these physical meetings or real-time meetings. And I must thank API KOCHI chapter for this great opportunity given to me. So you must wonder why this old Time magazine. This was the Time report about the front page Eisenhower, the man who beat Hitler. And it was in 1944, June 6, the future president of David Eisenhower. He was the supreme commander of the Allied forces in World War II, and he was addressing his soldiers, and he was telling, eyes are upon you, the eyes of the world are upon you. And he called that operation is Operation Overload, and it was nothing they will accept. He was not ready to accept anything other than the full victory. I put this because what happened to Eisenhower later in 1955, there is a connection between President Eisenhower and the oral anticoagulants. He had a massive heart attack in Denver when he was playing golf in the city of Colorado. He was admitted into military hospital, no drugs at that time. Only drug he was started on was heparin, and later with oral anticoagulation, 35 milligram per week of Warfarin. That was found to be effective, and that's how Warfarin became a very popular drug. Though Warfarin is a very popular drug, a time-stood drug, it was introduced in late 1940s, and now it stood the test of time for long years, almost 70 years. But a huge burden of Warfarin, which all of you know. I'm not going into the Warfarin issue, what is the advantage of Noac over Warfarin, what are the different studies of Warfarin, which I think you might have heard it many times. Only one thing, these 4 trials, the Rely, Rocket, Aristotle, Engage AF, which started in 2009, And the data came in 2009 with the dabigatran, 2011 with the Rocket AF, and 2012 with the Aristotle, and then Rivaroxaban in 2012. So all these data, excellent data, they found the they made the foundation for the use of this drug, which was later on incorporated in the guidelines, and now this is the preferred oral anticoagulants in most of the situations where oral anticoagulation is warranted. So I'll discuss some of the aspects where we always debate. With the help of a case, a 68 years old female, diabetic, hypertensive, she had a transient ischemic attack in the past, and she has non-valvular atrial fibrillation with a creatinine of 1.45 and weight of 68 kilogram. So the questions are, does she require a stroke prevention in atrial fibrillation with oral anticoagulation? If so, is it a NOAC or a vitamin K antagonist, and what is the dose? Is it the drug on a food or on an empty stomach? So if you look at it, the CHARTS-2 score is the score that we use. She is hypertensive, she has diabetes, she had a TIA, her age is 65, that is between the 65 and 71, she is female. So it is 2 plus 4, 6 out of this 9, so it's a high score, high risk of stroke, so she should be protected with stroke prevention in atrial fibrillation. And the current recommendation from the ESC is, when you require a stroke prevention in atrial fibrillation in a patient with non-valvular atrial fibrillation, NOAC is preferred over Warfarin. And regarding the pharmacokinetics, it's important. Dabigatran, it has got an interaction with the PGP, and bioavailability is very small. It's hardly 7% is bioavailability, highly hydrolyzed by the esterases, and the half-life is close to 17 hours. 80% is excreted through kidneys. That is the most important thing. In renal dysfunction, a major problem with dabigatran. Apixaban has the least excretion through kidneys, 27%. Bioavailability is better, it is 50% bioavailability. It has also got interaction with the drugs that affect the PGP, either inducers or strong inhibitors. And Rivaroxaban, we don't have Rivaroxaban available with us. Rivaroxaban also, it is 35% renally excreted, some interaction with the PGP, and the half-life is almost similar for almost all these drugs except dabigatran. The dabigatran is a twice-a-day drug. Apixaban has to be given twice a day, and Rivaroxaban is one drug which can be given only once a day. And Rivaroxaban, it is 66% absorption with food, without food, and if you take it with food, it is 100% absorption. So the question, which drug has to be taken with food? Rivaroxaban should be taken with food. And for every patient, when you start the NOAC, you have to calculate the EGFR, and the EGFR, though there are different methods like this MD equation as well as the CKD-EPI equation. This for use of this NOAC EGFR to be calculated using the Cockcroft formula, and this patient, the Cockcroft Gold formula, it is 46 is the EGFR. Cutoff for EGFR for most of the NOACs, it is 30. For Apixaban, it is 25 in the major trials. And how often should you check the EGFR? If the age is more than 75 years or a frail patient, at least once in 4 months, especially dabigatran. And if the creatinine clearance is less than 60, you divide the creatinine clearance with 10. So if it is 60, it is once in 6 months. If it is 40, once in 4 months. If it is 20, once in 2 months. And if it is 10, once in a month. And also when the situation changes, like the scenario changes when she is admitted with an intercurrent illness, infection, surgery, renal dysfunction, renal function deteriorates, where a hepatic function abnormality with dehydration, NSAIDs and all, you may have to check more frequently. And if the patient is bedridden and cannot take the drug, can we crush the drug and give it? Dabigatran should not be crushed. Apixaban and Rivaroxaban can be crushed for a Riles tube administration. This is a 63 years old male, severe mitral regurgitation, underwent MVR, bioprosthetic valve, persistent atrial fibrillation. So this is a prosthetic valve, but it's a bioprosthetic valve. Is it NOAC or a vitamin K? Now we have a data which shows that we can use Rivaroxaban in patients with atrial fibrillation and bioprosthetic mitral valve. So the previous studies like Aristotle, Engage, TIMI and all, they had very few patients, and in Rocket-AF with the Rivaroxaban bioprosthetic valves were excluded. So Rivaroxaban versus Warfarin. At the end of 1 year follow-up period, event-free survival time was days longer with Rivaroxaban compared with Warfarin. So no mortality benefit, but at the same time, the bleeding events, it was much less with Rivaroxaban when compared to Warfarin. So patients with atrial fibrillation and a bioprosthetic mitral valve, Rivaroxaban is non-inferior to Warfarin with respect to mean time free from death, major cardiovascular events and major bleeding. So we can use Rivaroxaban instead of Warfarin, especially in the times of this pandemic. It's extremely difficult for us to ask the patient to come with their relatives for regular monitoring of INR. So in a bioprosthetic valve, there is no issue. Another is a 45-year-old male MVP severe MR AF. Can we use? This is a valve disease. Though it is a valve disease, non-valvular AF means the AF in all the other conditions except a mechanical prosthetic valve or a patient with a rheumatic mitral stenosis moderate to severe. So mitral regurgitation, mitral valve prolapse, atrial fibrillation for a stroke prevention, there is no problem in using oral anticoagulation. But this patient, mitral stenosis, you can see the mitral stenosis with a ball valve thrombus, the mitral stenosis with a ball valve thrombus, mitral stenosis, rheumatic, severe and moderate. Right now also, there is no indication for Noac. This is because most of these patients were excluded in the trials, major trials. Otherwise, there is no much rationale. There are new trials coming up where they are using, they're trying non-vitamin K oral anticoagulation in patients with rheumatic mitral stenosis. I'm sure we'll have a positive data soon. So what is it? Mechanical prosthetic valve. No Noac, it is contraindicated. You cannot use. Majority of the studies have shown that it is detrimental. Moderate to severe mitral stenosis, you can say it is not red, but it is something like close to red. Excluded from the pivotal randomized control trial, there is no much rationale for its less efficacy or safety versus vitamin K antagonists. And other valvular heart diseases like degenerative aortic stenosis, mitral regurgitation, no issues. And bioprosthetic valve, now we have data with the RIVER study. So rheumatic mitral stenosis, mechanical prosthetic valves, we can't use Noac. But there are certain situations where when you cannot use a warfarin, off-label, we may use it after discussion with the patient. Diabetic hypertensive with a creatinine of 2.2 with CKD, weight is 54, paroxysmal AF, can we use Noac in this patient? I've mentioned renal function is the most important Achilles heel for the use of these group of drugs. So if you calculate it with the Koch-Gold equation, the eGFR is 22. So for even apixaban, major trials less than 25, it was excluded. So if you look at the major drugs that we use, dabigatran, rivaroxaban and apixaban, dabigatran up to 50 ml, 150 milligram twice a day, there's no issue. And when the eGFR is lower, we may err towards a lower dose of 110 milligram twice a day up to 30. And in those patients below 30, it may not be used, but in US, they may be using a 75 milligram twice a day between 15 and 30. Rivaroxaban, it is very clear, above 50, it is 20 milligram, 30 to 49, it is 15 milligram, and less than 30 up to 15 milligram. And apixaban, it depends upon if it's a good renal function, up to 30 ml, it is mostly 5 milligram per twice a day, unless they have other things like a low body weight and age more than 80. And most of the package insertion recommendation is against the use of it in those patients with end-stage renal disease or dialysis. We have limited data with apixaban as well as rivaroxaban smaller dosage. And this study in patients with end-stage kidney disease and atrial fibrillation in the United States, they use apixaban, even 5 milligram twice a day, and they found their bleeding risk was low. There was a reduction even in mortality. And so it has been included in the 2019 recommendations of American Heart Association, a class 2B recommendation. So those patients with AF, in whom it is stroke protection against atrial fibrillation is required and on dialysis, that is eGFR less than 15, it might be reasonable to prescribe Apixaban. So it may be very careful, you should be very careful. And you are discussing about liver, renal dysfunction. So what about the liver dysfunction? You calculate the puke score, child score, and if the child score A less than 7 points, all the drugs normal dosage. 7 to 9 points, it is used with caution, and if it is C more than 9 points, it is not recommended, and Rivaroxaban is not recommended with the class B also. Other Apixaban may be used. A 70-year-old male on dabigatran for stroke prevention. He met with a road traffic accident and developed rupture of spleen and liver laceration, needs urgent surgery. Now, we want to know, how do we know whether dabigatran is at therapeutic level, and what should be the best course of anticoagulation management in this guy? So, levels of Noac's. The blood levels of the Noac is the most important test when we have a question regarding whether the adequate level of anticoagulation is there or not. We don't look at it. We don't have facilities to look at it. So it's out of question. It is for a theoretical benefit. If we want to look at it, this is the way. Now it's available with most of the research setup, but major metropolis and in Western countries, it's available. PT, APTT, ACT is of no much value. They may be little increased in these patients who are on these drugs, but they are not reliable regarding looking at the efficacy or whether the patients are taking these drugs or not taking these drugs. Thrombin time is good in looking at the dabigatran, and if it is normal value, it excludes the presence of dabigatran. So routine coagulation test, it cannot provide accurate assessment of Noac anticoagulation. And a thrombophily, if you want to assess thrombophily, you have to stop the Noac and then send him for the workup. And the plasma levels of these drugs may be looked at in major bleeding, acute stroke, very complex drug-to-drug interactions, and if the patient is going for a surgery. So if the bleeding occurs in a patient who is on Noac, first thing, when did he took the last dose? Second, what is his renal function? Are there any other concomitant medication using? Then you look at the rapid anticoagulation assessment, the plasma drug level, if available, mild bleeding, delay or discontinue the next dose and reconsider concomitant medication, and choice of Noac and dosing may be corrected. And non-life-threatening major bleeding, other methods like the mechanical compression, endoscopic hemostasis, or all these things, and correct it with fluid replacement, the volume can be corrected. And for dabigatran, this is a situation where you can think of the agent which can correct it, the neutralizing agent or the antidote, which is idaracizumab. Or another good thing is hemodialysis can remove the drug entirely. And if it is a life-threatening bleeding for dabigatran treated patient, we can give idaracizumab. It is 2.5 plus 2.5, 5 grams IV. And for patients on Apixaban or Rivaroxaban, it is Anticoagulant alpha, which is not available with us. If these two drugs are not available, what we can use is prothrombin complex concentrate or activated prothrombin complex concentrate. It's mostly, I don't know which of the blood banks have this. I check with our blood bank, they don't have it. And FFP is of no much value. So if the patient comes to an acute emergency procedure, blood sampling, full coagulation profile, and if you have a reversal agent available, reverse it and then go for the surgery. So this patient definitely requires a reversal with idaracizumab and take him to the theater straight away. Then later on repeat the coagulation panel, and once the hemostasis is completely achieved and the surgeon is happy that he can be put back on anticoagulation, he can be put back. But if the surgery can be deferred for 24 hours, these are drugs whose half-life is so small, the effect comes down by at the end of 24 hours, so you wait and repeat coagulation panel. Look at the residual effect. If there is no much effect, we can straight away take the patient for operation with caution. And if we can defer the surgery for 3 days or so, that is expedite procedure, there is no issue. The drug effect will be after 72 hours unlikely to have any residual effect of Noac, except in patients with end-stage renal disease. So 54-year-old hypertensive diabetic on Rivaroxaban. He presented with an ischemic stroke, 2-hour window period, blood pressure is 148/80, creatinine clearance is 43. Last dose of Rivaroxaban taken the night prior to admission. This is the golden period for a thrombolysis. This is the time when you can take up the patient even for an intervention. What is the management? These are the things that we are going to face. You do have facilities for looking at the plasma level. If you can look at the plasma level, then of course, if it is less than 30, it is safe. There is no effective drug level in this patient and you can go ahead with thrombolysis. But this is not an option for us. Last NOAC intake is more than 48 hours and it is it's a normal renal function. Can go ahead with thrombolytic therapy. But patient like this, the last night they took the drug, and if it is dabigatran, give idarosizumab, reverse it, take the patient for thrombolysis. Immediately you can reverse it. Apixaban and all, the problem is it may take an infusion, so it may take a longer time. By that time he may be out of the winter period. And if the intake of the drug is more than 48 hours ago and it is a normal renal function, then you can thrombolysis. So if these options are not there, patient took the drug 12 hours ago, renal function may be a little impaired, we cannot look at the plasma level, then you cannot use thrombolysis, but you have to proceed with the endovascular thrombectomy if possible. 40-year diabetic hypertensive AF on vitamin K antagonist and developed a transient ischemic attack at an INR of 2.8. Can we consider a shift to NOAC? So the patient on vitamin K developing a TIA, therapeutic INR, of course, I would prefer to shift over to NOAC. So how from vitamin K to NOAC? You stop the vitamin K antagonist. It takes 2 or 3 days for the INR to normalize or start normalizing. By day 3, you look at the INR. If the INR is more than 3, wait. If the INR is less than 2, start NOAC straight away. INR is 2 to 2.5, wait for a day or so. The very next day, you can go ahead with most likely the INR will go below 2 and then you can start the NOAC. 2.5 to 3, again recheck in 2 to 3 days time and then start on NOAC. And NOAC to vitamin K. So patient on daily NOAC, continue the NOAC, along with you can start vitamin K antagonist. By 3 days, the vitamin K antagonist starts acting. You check the INR. Continue the NOAC till the INR is more than 2. Once the INR goes about 2, I would prefer for 2 consecutive days, you stop the NOAC and put them back entirely on oral anticoagulant, vitamin K antagonist. From unfractionated heparin to NOAC, stop the heparin after 4 hours, start the unfractionated heparin. Daily NOAC, so start unfractionated heparin. If the drug is given twice a day, the NOAC is a drug which is given twice a day like dabigatran. Stop after after 12 hours of the dose of dabigatran, you can start, then stop the dabigatran. If it is once a day drug like Rivaroxaban, after 24 hours of the last NOAC dose, you can put the patient on heparin. So 65 years old female, Rivaroxaban, scheduled for a COVID vaccination after 3 days. And then every day we get questions, when to stop Rivaroxaban prior to vaccination? No need to stop NOAC. The recommendation is leave out the morning dose of NOAC prior to the IM injection. Use a fine gauge needle. We are using for vaccination excellent needle. We don't even feel a pain. Firm pressure for at least 5 minutes. For an extra care, I always tell my patients to press for 10 to 15 minutes so that they will press for at least 5 minutes. If it is a single day dose of NOAC, take the left out morning dose at least 3 hours after the injection. And BID NOACs, restart NOAC the next scheduled dose. So there is no need to stop this drug before vaccination. And for a surgery, if a surgery is contemplated, elective surgery is contemplated, how to stop? Look at the creatinine clearance and the last dose. Creatinine clearance more than 80 for dabigatran, low risk procedures, stop it 24 hours before. 50 to 79, 36 hours before, and 30 to 49, 48 hours before. And high risk is double, 48 hours, 72 hours, 96 hours. So the highest risk surgery and lower creatinine clearance for dabigatran, we have to wait for at least 96 hours. For the other drugs, low risk, 24 hours, high risk, 48 hours. And 15 to 29, it may be 36 hours. Serum creatinine borderline less than 15. Less than 30 up to 15, we may stop it 36 hours prior. So it is basically the creatinine clearance that determines when to stop the drug. And the commonest surgeries, minor risk interventions. So for minor risk interventions, perform the procedure at the trough level of NOAC. There is no need to discontinue. So if the NOAC is taken at night, twice a day drug dosage, at night, the morning, after 12 hours, you can do the procedure like dental extractions, cataract, glaucoma, endoscopy without biopsy. Superficial surgeries like abscess incision, pacemaker implantation, so routine elective coronary angiography. So these things are low risk, minor risk interventions where you don't have to stop the drug. Low risk are commonest is complex dental procedures, endoscopy with renal biopsy, and small orthopedic surgeries. All the others are major risk surgeries. 64-year-old patient on chemotherapy with doxorubicin regime, he developed a DVT. Can we put this patient on NOAC? Doxorubicin vinblastine, no NOAC. This blue means it is due to the CYP3A4 interaction, it reduces the drug level. We will not get effective drug level. So doxorubicin and vinblastine, better avoid NOAC. This immunomodulating agent, tacrolimus, mostly you avoid. Cyclosporin, you avoid dabigatran. Avoid dabigatran. Other drugs, be careful. And this enzalutamide, arbiterone, nothing, no NOAC. Arbiterone, enzalutamide, vanatabib, imatinib, crisoniantib, all these things, no NOAC. And verapamil, you have to reduce the dose of dabigatran. Rifampicin, no dabigatran, no apixaban, no rivaroxaban, basically because of the induction of the PGP, high metabolism, so it reduces the drug level. Ketoconazole, itraconazole, avoid. Ritonavir and other HIV protease inhibitors, no. So these are the drugs I think that you may come across. We may not come across these drugs, but you may come across these drugs. These are the situations where you should not use this drug. Valproic acid, better avoid this drug because the drug level will be very low because of the strong PGP induction. Carbamazepine, dabigatran should be avoided, rivaroxaban should be avoided. We may use apixaban. Phenytoin, same way, dabigatran should be avoided, rivaroxaban. So be very careful when it is antiepileptic agents, immunomodulators, some of the oncology medications. 32-year female, 4 months pregnant, presented with pulmonary embolism after a long distance flight journey, treated with heparin, stable now. Can we shift over to oral anticoagulation with NOAC for the VTE prevention? NOAC is absolutely contraindicated in pregnancy, no data in children, but we may use it in adolescent above the weight 50 kilogram. It is a off-label indication. There is some data on VTE in children with the use of rivaroxaban, dabigatran. Pregnancy, absolutely no. A 67 years old male, diabetic hypertensive, chronic coronary syndrome, intermittent claudication, one toe amputated 2 years ago, TIA 1 year ago. So this is a patient with polyvascular disease. So polyvascular disease, and this is a patient who is on dual antiplatelet therapy, telmisartan, atorvastatin, metformin and insulin. How do we optimize this current drug regime? So we have the concept of dual pathway inhibition, antiplatelet plus antithrombotic therapy in chronic coronary syndrome. This data of COMBUS, because now this is the era of the COMBUS population. We are looking and trying to identify the COMBUS population. That is patients with coronary artery disease, either a previous MI or a multivessel coronary artery disease who had undergone PTCA or CABG for this thing, plus age more than 65 years or additional 2 risk factors like a diabetes, low EGFR, heart failure, or a stroke except a lacunar stroke, and involvement of atherosclerosis in more than 2 vascular beds, or in a peripheral arterial disease patient. These patients were tried in the large number of patients, 27,000 plus patients, tried with rivaroxaban 2.5 milligram twice a day. This is one situation where rivaroxaban was tried twice a day plus aspirin versus rivaroxaban 5 milligram twice a day versus aspirin alone. This trial was prematurely discontinued due to the great benefit. 4.1% with rivaroxaban and aspirin, 4.9% with rivaroxaban, 5.4% with aspirin, that is death, MI or stroke. Not only that, the benefit continues, the risk reduces. The risk of bleeding reduces after 1 year. So as the time goes on, the benefit of rivaroxaban plus aspirin continues, and after 1 year, mostly it is a net clinical benefit and the benefits accumulates over the time. Bleeding may not be a big problem. Multiple benefits. Reduction in the major adverse cardiac events, reduction in the death, reduction in the stroke. It is much better than other agents which were found to be effective in the 3 endpoints like SGLT2 inhibitors, PCSK9 inhibitor, or lipid lowering therapy. So, direct oral anticoagulant dosing. This is one very important thing. Appropriate dosing is crucial. Underdosing increases the risk of thromboembolism, and lower dose should be only as per published and approved dose reduction criteria. Dabigatran 110 mg BD if the age is more than 80, concomitant verapamil, high risk of GI bleed. Rivaroxaban, apixaban, serum creatinine 1.5, age more than 80, weight less than 60. So lower dose of apixaban if at least 2 of these are present. Lower dose of inappropriate, lower dose of apixaban has been found to be more problematic than the the warfarin. So it increases mortality. So always correct dose is extremely important. And 15 milligram of rivaroxaban if the creatinine clearance is between 15 and 49. So these are the drugs dosage used in stroke prevention in atrial fibrillation. Post PCI we may use a lower dose of the drug. Dose reduction after PCI when you are using a dual antiplatelet therapy, 110 milligram of dabigatran and 15 milligram of rivaroxaban. And it is 10 milligram of rivaroxaban for triple therapy if the creatinine clearance is between 30 and 49. Venous thromboembolism, higher dose during the initial 7 days for apixaban, 10 milligram twice a day, followed by 5 milligram twice a day. And dabigatran, 150 milligram twice a day, no dose reduction or no dose escalation. Rivaroxaban, 20 milligram, 15 milligram twice a day for 3 weeks, followed by 20 milligram later on. And extended therapy, it is 2.5 milligram apixaban, dabigatran 150 milligram BD, and rivaroxaban 10 milligram OD. We have the rivaroxaban 10 milligram. Where do we use it? Long-term prevention of DVT. VT prophylaxis following a major orthosurgery. A triple therapy when the creatinine clearance is 30 to 49 per minute. And VT prophylaxis in COVID-19 infection. Mortality in patients with atrial fibrillation receiving non-recommended doses of direct oral anticoagulants high with apixaban, dabigatran, and rivaroxaban. So the correct dose is extremely important. And you can see 60% of the patients in India, but very low number of patients recruited in this study. From India only 44 patients, but underdosing was quite frequent. So this is the Garfield AF registry. Those who received the recommended diagnosis according to the country specific guidelines, prescription of non-recommended doses was associated with the increased risk of death, mostly cardiovascular death compared with patients on recommended doses. So this is a problem which we should be very careful. You can see Noac'S approved doses regarding the weight more than 60 up to 120 it is fine. Above 120 plus or minus above 140 Noac cannot be used. Less than 50 it is better to avoid Noac or be very careful. And this is the problem. Predictors, time course and outcomes of persistent patterns in oral anticoagulation. You can see in the Western country from 88% it could be reduced to 72% in the persistence of the use of Noac's over 4 years. So in patients in whom there is a correct indication, our aim should be to promote the persistence and adherence to therapy. Our study, the Kerala Atrial Fibrillation Registry, the Noac usage was close to 8%, but this was a little longer back before the introduction of the generic Noacs. Now with the introduction of generic Noacs, I think the take-up of Noacs have increased. So current priority is to improve the adherence. We are clear about the indications. We know where to use it. We know what is the drug, what is the dosage to be used, and which drug to be used. There is no much difference between all the drugs, and there are no head-to-head comparisons also. So priority is to improve the adherence and persistence of oral anticoagulation. That is the most important thing. And let me conclude with the statement of Da Vinci. I've been impressed with the urgency of doing. Knowing is not enough, we must apply. So now the importance is for the application science. Being willing is not enough, we must do it. Thank you so much.
Thank you, Dr. JABIR. Excellent talk with full of practical wisdom. Many take-home messages. Beware of the kidneys, beware of the liver, beware of the other drugs being used. Individualize the treatment. And age, keep a watch on the drug should be individualized. And of course, I think we should be careful about the purse of the patient also. Any questions?
A purse of the patient, madam, there is a problem. So if we look at the warfarin, in normal situations, old patient, most of these patients are atrial fibrillation old patients. They are brought by two bystanders. They lose their wages on that particular day. They have to come, sit in the OPD, sit there for a day, most likely 4 or 5 hours. They may hire a taxi and come. And when we see the INR is 1.5, we'll ask, please come after 1 week again with INR. If this process goes on, at the end of 1 year, if we calculate these things together and NOAC, where there is no need of routine monitoring, I think NOAC is cost effective. And it takes away a lot of inconvenience to the patient as well as to the bystanders.
Excuse me, like Dr. JB, I got one serious doubt. When a patient is put on warfarin, we got an advantage. They will definitely come back to us with
Absolutely.
an INR.
I fully agree. That is the most important advantage of warfarin. You can ensure that the patient is taking the drug.
Exactly.
Taking the drug in the correct dosage.
Yes.
That is a great advantage of warfarin. I fully agree with you.
Novac, there is a problem. They may not find any reason to visit the doctor. They may continue to take a less required dose. And as you have shown the graph, there's a serious consequence if the dosages are suboptimal.
If it is an inappropriate dosage, it is a problem. It's a problem with NOAC. So as you said, we do not know whether the patient is really taking the drug or not. Warfarin has an advantage. We know that the patient is either taking the drug or not taking the drug. I fully agree.
Patients, how long do you recommend Rivaroxaban?
We have not data, we may tell that there is a consensus up to the use of 42 days. But now, more and more literature is coming up which is saying that there may not be indication in many cases. Indication is basically, there is a scoring system. It's very difficult to remember it offhand. There is a scoring system by which you can decide on which patient needs long-term prophylaxis or those who do not require long-term prophylaxis. But this is required only in those patients who were hospitalized, and mostly not only hospitalized, in ICU patients. So I think it is the viral load, the severity of the illness. A severe COVID, more viral load and more cytokine storm. So these are group of people who is going to benefit. These are the people who are developing thrombosis. Not all patients. OPD patients, domiciliary treatment patient, they don't have any indication for this drug.
Any other questions?
Sir, I have two questions, sir. My first question is, among the novel anticoagulants, which one do you prefer the most, sir?
It depends on many things. One, the renal function. Second, any things like, for example, the patient has multiple comorbidities. Then the third, what is the financial status of the patient? And what is the bleeding risk of the patient? Any patient with a high bleeding risk, I would prefer Apixaban, which has the highest safety profile. A patient who has, as madam said, if the pocket toxicity is high, I'll go for a generic Rivaroxaban. That is the cheapest right now available. Dabigatran has to be given twice a day. And renal function impairment, I'll again prefer a Rivaroxaban or a Apixaban. Apixaban has got better data, so Apixaban or Rivaroxaban. Any patient with a GI bleed or GI problems, I'll go for an Apixaban. Very elderly patient, frail patient, then whose bleeding risk is high, I'll prefer a Apixaban. So it depends. And for a combus population, it is Rivaroxaban. So it depends. You have to look at various aspects.
Thank you, sir. My second doubt is in chronic coronary syndrome, sir. You mentioned that we can use Rivaroxaban along
Yes.
with antiplatelets. So, at what dose do we give?
2.5 milligram twice a day, and aspirin is 100 milligram they have used. But what I do in my practice is I use 2.5 milligram twice a day of Rivaroxaban plus clopidogrel I prefer, because I'm a little bit afraid of the aspirin with the anticoagulation. There is no data. This is strictly a personal preference, that's all. The data available is with aspirin. But in theirs, There was increased bleeding with aspirin and Rivaroxaban, but the benefit was high. So this is specifically useful, beneficial in patients with peripheral arterial disease, ulcers, polyvascular disease, patients who had a stroke before, now coronary artery disease, peripheral arterial disease, those patients with a mild to moderate renal dysfunction, polyvascular disease, diabetes, heart failure, polyvascular disease. So the atherothrombotic risk is high. This combination is better rather than a dual antiplatelet therapy. But the problem is we don't have a comparison with dual antiplatelet therapy. The comparison was with a single antiplatelet therapy.
Sir, my doubt there was, why not give it as 5 OD rather than 2.5 BD?
They looked at the 5 OD dosage. I also had this doubt. Nobody could give me a correct answer why it was given 2.5 milligram twice a day. Maybe due to the fact that though we are giving once a day, if you look at the pharmacological profile, its termination, the elimination half-life is only 13 hours. So maybe ensuring the complete protection, and this is the dose which was used in the acute coronary syndrome also. That may be the reason. I could not find a definite answer why it was used twice a day.
Thank you, sir. Sir, and my third doubt is, in a patient with dual antiplatelet, if we are starting one of the NOCs, is it better to make it a single antiplatelet?
Definitely, no doubt. Even in post-PCI patients, if I do a percutaneous coronary intervention for a patient with acute MI today, and he has atrial fibrillation and requires oral anticoagulation, what we do is always use clopidogrel. We don't go for the newer agents like potent agents like ticagrelor or prasugrel. It's clopidogrel, lower dose of aspirin, 75 milligram, and the oral anticoagulation also dabigatran 110, Rivaroxaban it is 15 milligram, apixaban it is 5 milligram, and we give it for 1 week to 1 month, this triple therapy, not more than a month. Then change it over to a single antiplatelet agent plus oral anticoagulant. And single antiplatelet agent, the preferred one is clopidogrel rather than aspirin.
Thank you, sir.
If there are no more questions, I think we'll conclude the session. Thank you, Dr. JABIR, for an excellent talk. And I must say, very happy to be, home today.
Good evening, everyone. We'll have the mementos for the speakers as well as the chairperson. May I request Dr. A.P. Radhakrishnan to hand over the memento to Dr. Preeti Paul from Lakeshore Hospital. Dr. Preeti Paul, please come. Oh, I'm sorry. Okay. Dr. JABIR. That's okay. That's okay. One minute. Okay. May I now request Dr. Prasanna Kumar to hand over the memento to Dr. Joseph K. Joseph from Lakeshore Hospital. May I request Dr. Srinivas Kamath, sir, to hand over the memento to Dr. SHYAMALA Menon. Thank you, sir. May I request Dr. Madhukumar, sir, to present the memento to Dr. Preeti Paul. So, thank you, everyone. It's so nice to see everyone here. And it would have been better if we had more participation. I think it's safe to remove the mask now. Regarding the last meeting, which was a virtual one, it was held on October 24th. And there was a good speaker from Delhi, Dr. Vineet Bhatia. September 24th. Yeah. and a speaker from Delhi, Dr. Vineet Bhatia, who was a cardiologist, who spoke on acute pulmonary embolism. The session was chaired by Dr. K. Hari, and it was followed by a very good case discussion on leptospirosis. It was an unusual case presented from Kolanchery Medical College, and it was presented by Dr. Vishnu Tangappan, who's a medical student there, and it was moderated by Dr. Abraham Etiachen. It was a very interesting session and received well by all the API members and appreciated. Now, one or two things. We have the API Association has got a proposal from a company called Mojini for teleconsultation app. So we are in discussion with the company people as well as with our legal advisor, Mr. Vishwanathan, and we'll come up with a proposition and present it in the next meeting, and take your advice and go ahead in accepting the proposal. Coming to the vote of thanks. Let me start by thanking Dr. Preeti Paul, for DNB student from Lakeshore Hospital, for an excellent clinical case presentation, and Dr. Joseph K. Joseph, consultant in the Department of Internal Medicine from Lakeshore Hospital, for having expertly moderated the session, leading up to a very fruitful discussion on the case. I thank today's guest speaker, Dr. JABIR A, senior consultant from Department of Cardiology, Lisie Hospital, for having very skillfully navigated us through the topic of novel oral anticoagulants. Thank you, Dr. SHYAMALA Menon, a senior consultant at Department of Internal Medicine, Medical Trust Hospital, for having chaired the session and enlightened us all with her scientific observations and expert comments on the subject. My sincere thanks to the audiovisual team led by Mr. Arun Moses and Mr. Inish for their constant and unwavering support. My gratitude towards Sun Pharma for having sponsored today's scientific session. Last but not the least, let me thank each and every API member who has attended this meeting today, physically and virtually, and thank you for encouraging us with your valuable presence. I now hand over the mic to the Chairman API, Dr. A.P. Radhakrishnan.
Thank you all the participants and the speakers for making today's session a success.